Welcome back to Jabstudiesmetfun for Anesthesia Part 5. For this part, we're going to discuss about local anesthesia and inhalational types of anesthesia. So mostly we're going to cover around 30 to 40 marks and make sure you know each and every line in which we're going to discuss right now. So without further ado, let's start. So first we'll talk about local anesthesia. So if you talk about the local anesthetics, it is basically divided into two types. It's going to be the ester groups and the amide groups. Okay. So what are the difference between both of them? First of all, need to know that the amide groups are the ones which are stable in nature. These are the ones which are stable. Okay. And then you need to know that how do they get metabolized? They get metabolized by the liver. Among the amide, the only exception which does not get metabolized by the liver is going to be atrakane. Okay. Then we'll have the ester groups. Ester groups are the ones which are unstable and they are the one which are metabolized by plasma esterase. So ester group and the plasma esterase. The exception for this is going to be your cocaine. Okay, the exception is going to be cocaine. So these are the two things which you need to know in difference. One which is a stable one, amide, which are the not stable one, that is going to be ester. Now in the local anesthetics, which are the drugs which come under amide groups and which are the ones which come under ester groups? As you can see in amide, there is an I. So wherever there are two I's within the same drug, like lignocaine has two I's, bupivacaine also has two I's. Whenever in the local anesthetic there are two I's, remember it is going to be under the amide group. Whereas you can see ester has no I. So wherever there is a drug in which only there is one I. So remember this way, okay? Amide there is one I. So remember you'll have to, wherever there is a drug in two I's are there, that is going to be amide. In ester there is no I. So in whichever drug there is only one I, that is going to be an ester, like procaine, chloroprocaine, cocaine, benzocaine. I hope that is clear. Next, with respect to the duration of action, you can divide it into short acting, intermediate acting and long acting. In this, what you have to remember is the shortest acting. C for chota, C for chloroprocaine is the shortest acting one. Hence, they can be used for daycare procedures. Then you'll have the intermediate ones, lignocaine and prilocaine. Remember, the difference between procaine is different and prilocaine is different. Both also have different side effects. Procaine has related to drugs with it has some side effects related to sulfur drugs, whereas prilocaine can cause an effect which is methemoglobinemia, causing false pulse oximeter values. Okay, so remember with respect to short duration right now, that is going to be chloroprocaine is the shortest. Intermediate one is going to be lignocaine and prilocaine, and remember longest one, bupivacaine. We discussed this about in the last video. Remember bupivacaine number in case of succinylcholine, whether you need to know atypical pseudocholine esterase. Okay. Next, let's talk about what is the mechanism of action of your local anesthetics. So basically, guys, you need to know that the local anesthetics are going to be in the blood. In the blood, they have there are two forms of a local anesthetic. It is going to be ionized and non-ionized. In the blood, it acts as a non-ionized lipophilic form. When it goes into the cell, it becomes ionized and then it goes and blocks sodium channel blockers. Main action of, you will see, they'll ask you local anesthetic is sodium channel blockers. They do block potassium and calcium channels in a lower way, but majorly if they'll ask you, it is a sodium channel blocker. Now why is this happening? That whenever it goes into the cell, then only it is getting activated, then only it is getting ionized. The reason is within the cell the pH is low, which means the pH is more acidic. That is why it converts from non-ionized to ionized form. That is why if they'll ask you what is the mechanism, conversion from non-ionized to ionized form, in which the cell, within the cell, the pKa is quite less, it is more acidic, which gets it activated and thereby it blocks the sodium channel blocker. So in short, whatever is written over here, I have explained it in layman. One more time I will tell it. In the blood, it is lipophilic, it is non-ionized. When it goes within the cell, because of the pH is lower in the cell, it gets converted into ionized form and then it blocks the sodium channels. So remember what blockers they are the sodium channel blockers. Now remember, if there is any condition like pus, or if there is any condition where you will see there are debris or something like this, that time the tissue surrounding is going to be acidic in nature. So if it is going to be acidic in nature in the surrounding itself, the drug is going to get ionized within the blood only. So thereby at that local site of action, there won't be any effect of blocking. So that is why whenever the environment is acidic in nature, the effect of the drug is going to be low. Whenever the environment is basic in nature, whenever we are giving sodium bicarb, which is an alkali solution, so around that area, it won't get ionized. Directly, it will go into the cell in a faster way and get ionized. I hope you understand the mechanism of action. So let's talk about some general properties. If they'll ask you what are the best and the best potent sites, remember intercostal is the area where you'll have maximum blockage. Then talking about dosage, remember the normal dosage of lignocaine is going to be 3 to 5 milligram per kilogram. But if you add lignocaine with adrenaline, you can increase the dose up to 7 milligram per kilogram, because adrenaline, first of all, it reduces the systemic absorption, and the second thing is it increases its toxic dose limit. Okay, along with this, adrenaline, as I already told you, reduces the systemic circulation. If I talk about the lipid solubility, more the lipid soluble the drug, more the potent it is. Dose, more the dose, more effect also will be there. Correct? Again, same thing. Higher the concentration, more the potency. If the pH of the medium is more or less, remember pH acidic medium, which means it is going to be less. So remember, if the pH of the entire medium is going to be acidic, that time the drug is going to get dissolved whether in the blood itself, it does not reach the channel. So if it does not reach the cell, there won't be blockage of the sodium channel. Thereby, whenever you have any acidic medium, for example pus or something like this, the effect of the drug is going to be less potent. If you have an alkaline medium, the effect of the drug is going to be more potent. Clear? pKa, don't need to remember too much about this, but if you just correlate one thing, what I said you is the drug's pH, if it is close, the drug's pKa is closer to the pH of the cell, the potency is going to increase. So pKa should be similar to the pH of the cell. Now, between the comparison of lignocaine and bupivacaine, the pKa of lignocaine is quite similar to that of the cell. That is why it is more fast acting, because normal cell K is around 7.45. Over here you can see lignocaine is 7.7, because of which lignocaine is a faster acting as compared to bupivacaine, which has a pKa of 8.4. So remember the logic, pKa closer to pH will increase the potency. Cool. Next, if you ask about the onset type of myelinated fibers, smaller fibers, they'll get activated fast, and second is myelinated, because increase in conduction. So remember, small, you'll have to remember both small plus myelinated. Small plus myelinated fibers, these are the ones which will be having more fast effect and potency. And again, if you add sodium bicarbonate, as we already discussed, if sodium bicarbonate is added, which means the pH is going to increase, which means it's going to be alkali. So thereby it will not get dissolved outside itself. Directly it will go to the cell faster, and then it will go and block the sodium channel blockers. Thereby it will be quicker the onset of action. Cool. So whatever I told it, let's summarize it in a table itself. Quick onset. What are the factors which depend on quick onset? If there is more concentration, more will be the faster onset. pKa value as closer to the body pH, which is 7. For example, remember we just now talked about lignocaine had 7.7 as compared to bupivacaine, which had 8.4. So who will have a faster onset? Lignocaine. Very good. Small myelinated fibers. If you add sodium bicarbonate, why? Because you're making the medium alkali. If you talk about duration, which of the following increase the duration? One is obviously if you increase the dose, more will be the drug, more will be the duration. Then adrenaline. Remember, very importantly, what is the dose of adrenaline? In case of local anesthetic, it is going to be 1:200,000. Very important. Okay, if you see IV use in case of anaphylaxis, or in case of not in anaphylaxis, sorry, in case of ventricular fibrillation, when you're doing the advanced cardiac life support will be there. The ratio is 1:10,000. In what form? If you're doing this in IV, right, it is going to be 1:1000 in case of anaphylaxis IM dose. Even subcutaneous dose is the same. Even intratracheal dose is the same. Okay, so make sure you remember this. So they will come with history based. Lignocaine, the dose for adrenaline is going to be 1:200,000. You have a patient who is having anaphylactic shock. You have to give intramuscular adrenaline. What is the dose? 1:1000. Patient is right now having asystole. You found that there is no beats. What is the dose of adrenaline? If you're giving IV, it is going to be 1:10,000. Clear? Next, absorption. As I told you, maximum absorption at what site? It is going to be intercostals. Dosage also already done. Normal dosage of lignocaine 3 to 5. With adrenaline is going to be by 7. Bupivacaine and ropivacaine, the dose is going to be around 2 to 3 milligram per kilogram. And remember, ropivacaine is nowadays more preferred as compared to bupivacaine. Both of them are long acting ones, but ropivacaine is more preferred because bupivacaine has cardiovascular side effects. And what are the side effects? It causes ventricular arrhythmias. We'll talk about that right now. So if you're giving our dosage, okay, good. But what if we exceed our required normal dosage limit? Then there will be toxicity. The first sign which you find in toxicity is going to be circumoral tinnitus. That is going to be the first sign with all, which is a type of toxicity. After this, even if you still furthermore continue and the dose is getting more toxic, you can have seizures, which is generalized tonic-clonic seizures. And remember, these seizures are mostly commonly due to which drug? It is because of lignocaine. Okay, because of lignocaine, mostly you can see seizures will be there. And what is the treatment? You can give short-acting benzodiazepines like midazolam. Okay, short-acting benzodiazepines can be given like midazolam. Now, if you give benzocaine, like bupivacaine in a longer dose, if you give bupivacaine in a longer dose, you get cardiovascular side effects, which is ventricular arrhythmias, and this is very dangerous. And what is the management? You have to give 20% intralipid. You have to give 20% intralipid. Okay, that is the management. Next, doctors, if you will talk about the application of local anesthetics, you can use it in labor anesthesia. Now, in labor pain, you know that the 3 P's which are there. What are the 3 P's? You will tell me what are the 3 P's, because in obstetrics this is very important. They will ask you the P's, and out of A, B, C will be there and D will not be. Which of the following are 3 P's except? So make sure you comment below. Okay. So I'll just go avoiding this. I'll talk about the patho which I want to talk about is, if the patient is with the mother is feeling too much pain, they will not be able to push, which is one of the factors. Okay. Now, if you want to reduce the pain, but we want to reduce the sensory control, not the motor, otherwise the mother will not be able to push. So for that, what we are going to give, we are going to give a low dose of bupivacaine. A low dose of bupivacaine, which is going to be 0.125% bupivacaine, will block only the pain sensation. So pain sensation is basically sensory block, not motor block. We are going to do sensory block. Same thing right now, because as I told you, bupivacaine has side effects like ventricular arrhythmia. You can use ropivacaine, and the dose of ropivacaine for labor anesthesia is going to be 0.2%. Now, what is usmle? Usmle cream is basically a combination of lignocaine and prilocaine. They can be either 2.5% or they can be 5%. The main purpose of this usmle cream is surface anesthesia. Usually this can also be done in case of whenever a patient is trying to go through a laser, so they can provide a surface anesthesia, or maybe a child who's having severe pain, who cannot tolerate pain. You'll apply this over there in the surface with a sticker on the top. Around 45 minutes you'll wait. The patient will not feel pain. So the dosage, as I told you, it is a combination of lignocaine and prilocaine. Next we have to think, which we have to talk about, is beer block. Now what is beer block, guys? Basically what we're doing, we're taking a local anesthetic, we're putting it into the intravenous, but to avoid the systemic travel, what we are going to do is we're going to apply a tourniquet over here. You're going to apply a tourniquet. Now, what is the common drug which we use over here is we are going to use lignocaine. Why don't we use bupivacaine? Because just imagine if the tourniquet gets loosened up, bupivacaine goes and it can cause its effect, which is ventricular arrhythmia. Now you might think, why are we giving lignocaine? Because lignocaine also causes GTCS. GTCS can be controlled by giving midas, very good. But ventricular arrhythmia, which is much more riskier, that's why we do not prefer it, and we can prefer lignocaine or prilocaine. Okay, so remember beer block. What is beer block? It is a IV anesthetic purpose. Next, we'll be talking about cocaine. Now, in cocaine, you need to know there are 3 features. One is going to be, it is going to go systemic stimulation. It will cause dilatation of the eye, which is mydriasis. And why we stopped using it? Because it causes severe vasoconstriction. It causes severe vasoconstriction. Procaine, we don't prefer it because usually it interacts with sulfonamides. Okay. Chloroprocaine, which we told us is the shortest acting local anesthetic. That is why it is preferred in daycare surgeries. Prilocaine. Now what prilocaine does is it causes methglobinemia. What is methglobinemia is the conversion of Fe+2 to Fe+3. Thereby, when you will check the pulse ox, in pulse ox you will have falsely low SpO2 will be there. Okay. Lignocaine. What are the usually available forms of lignocaine? 5% spinal anesthesia, but we don't use it anymore because it can cause GTCS. If you talk about in case of gargles, it is present at 4%. Jelly form, which we just now talked, like usmle, can be present in 2%, and 1 to 2% in nerve blocks. Normal, if you will see what is the dosage, 3 to 5 milligram per kilogram. If you're adding adrenaline, it is going to be 7 milligram per kilogram. Ropivacaine is now more preferred than bupivacaine because it is less cardiotoxic and causes a good, and also it causes less motor blockage. So both are less. Okay, we want usually a sensory block, right? In case of labor anesthesia, not a motor one, we need a sensory one. So that's why ropivacaine causes less cardiotoxicity and less motor blockage. So this is all about local anesthetics. Let's talk about inhalational agents. Now, what is the purpose of inhalation agents? There are 2 things. One, to start the anesthesia, which means induction, and one, to maintain the anesthesia. In the inhalation agents, one thing what I want you guys to know is a Mayer-Overton rule. What is Mayer-Overton rule is, he says that lipid solubility is directly proportional to potency. Now, what is potency? Potency is minimum concentration of a drug causing maximum effect. Minimum concentration of a drug causing maximum effect. So how can you check potency? Now potency cannot be checked barely by saying, okay, this guy is sleeping too much to check the level of anesthesia, or sleeping less. We need some value. For this value, we have minimum alveolar concentration. Now what is minimum alveolar concentration? Minimum alveolar concentration says us that it is the minimum amount of drug which will cause immobility to a painful stimulus. For example, there is a painful stimulus. Now I am feeling pain. But how much drug do we need so that we will not feel pain? So basically we will be immobile to this painful stimulus. That is minimum alveolar concentration. The lower the minimum alveolar concentration value, the more potent it is. Which means if I have a drug to cause painless effect, it is causing 0.1, and the other drug too is you need 5% of it. Now which is more potent? This 0.1, because minimum alveolar concentration, one more time understand the meaning, it is the minimum amount of drug. जितना कम चाहिए कि जो दर्द है वो हट जाए. अगर एक ड्रग का ज्यादा डोज चाहिए, which means it is less potent. अगर एक ड्रग का कम डोज चाहिए, then that is more potent. So remember this thing, okay? And remember one more important thing. What was Mayer-Overton rule? That the lipid solubility is directly proportional to the potency. And also remember, minimum alveolar concentration is inversely proportional to potency. मतलब जितना कम MAC उतना ज़्यादा potency. I hope this is clear. This is the basic funda of inhalational agents. Before that, just remember, when we are talking about local anesthetics, these all things which I have discussed, all have been asked previously in Fmge, NEET, PG and INI. So make sure you go through this very nicely. If you have any other doubts, do text me out. Okay. So if you talk about inhalational agents, you need to know what are the aspects where it can get blocked. So see, this is the Boyle's machine in which we have all our setup. So there are three parts where it can get affected. From Boyle's machine up to reaching the alveoli, from the alveoli reaching the pulmonary circulation, and from the pulmonary circulation to reaching the various part of the body. That is three parts. So in these three parts, we are going to discuss what are the factors which are going to affect, increase or decrease or in the induction of the anesthetic. Okay, so we will talk about this one by one. So the first topic which we are going to talk about is factors which will be affecting from the machine to the alveoli. So first thing is concentration effect. If the concentration is going to be more, obviously the induction and the activity of the inhalation is also going to be more. So more the inspired concentration, quicker will be the induction of the inhalational agent. Now mostly if you see a child, usually before the inhalational agent or whenever you're giving anesthesia, child they are going to cry. So as they cry, they're inhaling also more. So more will be the concentration, quicker will be seen in children the induction. Next is second gas effect. If you see second gas effect, usually it is seen at the start of surgery. Second gas effect is because of nitrous oxide. Now you need to know that nitrous oxide diffuses about to 33 times faster. 33 times faster than oxygen. Okay, 33 times faster than oxygen. So what happens is, if you have nitrous oxide over here, it goes into the pulmonary circulation much more faster than the oxygen. Now what happens is that because the oxygen will be left over here, whenever the nitric oxide goes, it causes reduction in the alveolar size. So if the alveolar size is low, whatever oxygen was there, it is going to get concentrated more. Thereby, the oxygen level is going to get increased. I hope you understood. Whenever you are inspirating at this type of start of surgery, the nitrous oxide is going to get diffused faster into the pulmonary circulation, because of which it reduces the size of the alveoli. Thereby, the oxygen which is present within inside, that is going to get increased in concentration. So first, this is going to be your second gas effect. This is at the type of surgery. So because of the rapid diffusion capacity of the nitrous oxide, there will be a rapid onset of the second gas, which is oxygen. Then you see something which is completely opposite, that is going to be Fmge effect or diffusion hypoxia. If you think about this similarly, now what happens is at the time of the end, when we want to stop the surgery, now the nitrous oxide is going to be present over here in the pulmonary circulation. What it does is, it is going to come into the alveoli. Now whenever it comes to the alveoli, the size of the alveoli is going to increase. So if the size of the alveoli is going to increase, there will be limited amount of oxygen. So this much small oxygen in this much big bag, just imagine it like that. That is why you will have a temporary hypoxia. And this is known as diffusional hypoxia or Fmge effect. So remember, Fmge effect or diffusional hypoxia is seen at the end of the surgery, and it is opposite to second gas effect. In second gas effect, oxygen concentration was increasing. and in the Fink effect or diffusion hypoxia, oxygen ka level is decreasing. So that's why it is known as hypoxia. Alveolar ventilation. Again, baby is crying more, children are crying more inhalation of the drug. So that is why what will happen is they will be having increased uptake, so the induction will be faster. Functional residual capacity. Now, whenever you have a lower functional residual capacity, you will have a faster way to induce. So FRC is again smaller in children and in babies. That's why they get induced faster. Next, we will be talking about the transportation from the alveoli to the pulmonary circulation. In this, doctors, you have something which is a blood gas partial coefficient. Now, this B by G is equal to what is the concentration of the agent, whatever inhalational agent we are doing in the blood versus the concentration of that agent in the alveoli. Concentration of the agent in the blood divided by the concentration of the agent in the alveoli. If you talk about it, what does this mean? If in this of one particular agent, the B by G is more. If the B by G is more, which means that agent is more soluble in the blood, because of which it is going to be delayed in conduction, because now what is there, it is going to dissolve within to multiple tissues it will go. So to reach the brain, it is going to take a lot of time. So remember this rule, more soluble in the blood, less will be the induction. Next, if you see, if the blood B by G is going to be less, if B by G is less, which means it is less concentrated, it is less soluble in the blood, thereby it will be a quicker induction. So remember, whenever an agent is soluble, it is more soluble in blood, which means the concentration is also more, but it will be taking more time to induce. If you have less concentration within the blood, and then it will be less soluble, so basically it is floating on the top, so it will be very easily getting to the brain. So that is why, remember, what do you want in a drug? MAC should be less, so it is more potent, and B by G also should be less. Now in this, you have to remember, if you remember a mnemonic which is HISD. So remember, H means high. So remember, this is a ratio for B by G, in which halothane it should be there is going to be having the maximum one, followed by isoflurane, then sevoflurane and desflurane. This is the ratio of B by G. So obviously, which do we want more? We will be preferring desflurane will be there. Why? Because we want a lower B by G. So here you have to remember all of these values, because they have asked usually, and they will ask you to arrange in order. Arrange this inhalational agents based on the B by G ratio and MAC. So remember, first of all, the nitrous oxide has maximum MAC, which means it is very less potent. You need a lot of dose to cause that effect. Okay. Along with this, if you see, which has the minimum, methoxyflurane. Same here in B by G ratio, they will ask you to remember the order. So make sure you remember this order properly. Okay, somehow whatever mnemonic you have, that's why just for B by G I had this one, H high SID. So high SID. Okay, this is for B by G. This is the lower, and this H for high, so this will be higher. Okay. Next, let's talk about specific effects of the drugs in the systemic circulation. First, we'll be talking about pulmonary. Remember, guys, all inhalational agents are depressant. So remember, all inhalation agents are depressants. So mostly whatever system we're going to talk about it, they are going to depress all the actions. So first we'll be talking about pulmonary system. So what they're going to depress? They're going to depress the respiratory rate. So if you depress the respiratory rate, which are the following features are there in each one? Remember, first one we will be acting is the smell. Remember, guys, that sevoflurane is sweet, halothane is also sweet, but because in children we need something which is sweet. Now, how to compare between halothane and sevoflurane is, we prefer sevoflurane as the first choice in children because halothane has multiple cardiac abnormalities, which is bradyarrhythmia. So that is why we are preferring sevoflurane over halothane. First feature. Second thing is, remember this one, desflurane causes irritation. So that is why you don't want to irritate the child. You will not give desflurane in a child. And next thing is, isoflurane is very smelly. It is very pungent. That is why you're not going to give isoflurane as well. So what you will give in a child? Sevoflurane. Next, if you talk about bronchodilation, remember halothane has the maximum bronchodilation, but still we are preferring sevoflurane because again halothane has cardiac abnormalities. You don't give isoflurane and you don't give desflurane. Avoid. So remember, overall to summarize, for children what you will give? Sevoflurane more than halothane, and for children who are asthmatics, what you will give? Again sevoflurane more than halothane. Next, let's talk about cardiovascular. As I told you, what will happen? They all are depressant, so the heart rate and the blood pressure is going to fall. But maximum bradyarrhythmia is going to be seen in which? Halothane. That's why we were not preferring it. Maximum bradyarrhythmia is going to be there. Along with this, it sensitizes the myocardium to adrenaline. What happens is, if you sensitize the myocardium to adrenaline, whenever you give adrenaline, maybe if the patient had a history of shock and you give it, this will stimulate the myocardium, thereby there will be ventricular arrhythmias. So that's why we are not preferring halothane. Second, if you'll ask you which are the preferred ones in case of cardiac diseases, we are going to give cardiostable drugs, which is isoflurane, and another one which is going to be sevoflurane. Now, if they will ask you which one is cardiostable, which one is cardiostable, both, if their answer, if both is mentioned, both you have to mark iso and sevoflurane. Okay. If they'll ask you any one, remember you have to mark sevo more than iso. The reason is a theoretical reason that in which the isoflurane has something which is coronary steal phenomena. What is coronary steal phenomena is that it transfers the blood from ischemic area to non-ischemic area, which we don't want. This is theoretical aspect. That is why if they'll ask you, both are good, but if they'll ask you one, remember sevoflurane is something which we prefer over isoflurane. Next, if they'll ask you with respect to cardiovascular, regarding again why we are not giving desflurane, because it is an irritant. So in the starting it gives tachyarrhythmias. If you talk about the CNS, all the inhalation agents causes increase in the blood in the cerebral blood flow. If there is increase in the cerebral blood flow, there will be increase in intracranial hypertension. So remember that if they'll ask you again which is the maximum, they'll ask you the maximum increase will be by halothane. Maximum increase will be by halothane, that is maximum increase cerebral blood flow, and that's why it is contraindicated in neurosurgery. Other three drugs, which is iso, sevo and des, can be given in case of neurosurgery, because you can counter this raised intracranial pressure with the help of hyperventilation. When you do hyperventilation, there will be decrease in end-tidal capnography, thereby you will see there will be decrease in ICP. So you can use. If you talk about the GIT, all the 4 inhalational drugs, they are going to reduce the blood flow to the liver. They are going to reduce the blood flow by the liver. But who gives maximum reduction? Again, halothane. So it is very easy to remember halothane. Maximum bronchodilation, maximum bradyarrhythmia, maximum raise in ICP, maximum decrease in blood flow by the liver. So remember, it causes maximum decrease. Also, you don't give halothane to conditions like if there is an old person, a female, 40-year-old or multiple histories of halothane, again, you don't give them again, because it causes something which is known as halothane hepatitis. It causes something which is halothane hepatitis, thereby you don't prefer it. So if they'll ask you which one you do prefer, the one which we actually prefer is your desflurane. The reason we give desflurane is because it minimally metabolizes. So if there is less metabolism, even in case of any liver disease or something, we can prefer this one. Okay. If you talk about renal, in case of renal condition, guys, first of all, if you know that there is a difference between 2 of the drugs. One, you had inhalation agent which were old type, example ether, chloroform, and the newer ones are isoflurane, sevoflurane, desflurane and halothane. Now difference between both of them was that the older ones, which is ether and chloroform, they were inflammable, while if you see the newer ones, they are non-inflammable. The difference between them was made by whenever you add to the inhalation agent fluorine, that time it becomes non-inflammable. So that was good. But the side effect was whenever you give too much fluorine, it is going to cause nephrotoxicity. It is going to cause so whenever you give fluoride, it is going to cause nephrotoxicity. So that is why which drug, if they will ask you, is best in case of any kidney disease also, that time you can give both desflurane and isoflurane, but if they'll ask you one, that is going to be desflurane. Why we are not giving sevoflurane, which was also good in case of asthmatic patients, it was also good in case of children, because whenever for prolonged use, if you use combination of sevoflurane with soda lime, SS, whenever you use sevoflurane with soda lime, it produced a compound which is known as compound A, and this was found as nephrotoxic in lower vertebrates. It was not found in humans, but still there is chance of nephrotoxicity. That's why in any case of any AKI or any chronic kidney disease or any related kidney disease, we will prefer desflurane over isoflurane. In uterus, it causes uterine relaxation. That's why there is a small risk of postpartum hemorrhage. And with respect to teratogenicity, usually inhalation agents are not teratogenic, but they have found some teratogenicity with nitrous oxide. With respect to muscular system, all of them act as muscular relaxant, and they can help us to reduce the dose of muscular relaxant. Trialine, which is a good analgesic, which was an old type of inhalation anesthetic. Ocular, it causes reduction in IOP. The only increase was in intracranial pressure. Metabolism, if they'll ask you, maximum metabolism is done by halothane, whereas minimum is done by desflurane. If you talk about last, nitrous oxide, remember few features. We'll talk about the cylindrical slides later on. But remember, nitrous oxide is usually in the blue cylinder with the pressure of 160 psi. If you use nitrous oxide for a very long time, it can go and disturb the vitamin B12 metabolism, thereby causing megaloblastic anemia and subacute combined degeneration of the spinal cord. Thereby, you'll have paresthesia. Because nitrous oxide has a very high diffusing capacity, that is why you don't prefer it in case of pneumothorax, middle ear surgeries or ocular surgeries. You have a combination of N-10-ox, which is a combination of 50% oxygen and 50% nitrous oxide, and that is used for labor anesthesia. So make sure guys, you know this table very well. All of the things which you need to know in case of local anesthetic inhalation agent is given in this slide, this video. You only need to do this, do the PYQs, 5 years FMG, 5 years NEET PG, and 3 years of INA. It is more than enough. Again, remember what I was asking was, what are the 3 P's? This can come as a simple question, so make sure you know this in case of labor. Okay, I hope this topic was clear, and if you have any other doubts, do text me and meet in the next video. Take care, bye bye.